Good evening. I'm Dr. Anita Bakshi, and I'm speaking about disease specific ventilation. Disease specific ventilation is a very vast topic, so I'm aiming in this lecture to address a few salient points about the common diseases that we ventilate in PICU in our clinical practice. So, when we are ventilating, what are our targets in ventilation? Our main targets are good oxygenation, acceptable carbon dioxide levels, a near normal pH, reduced work of breathing, and all this to be managed with minimal damage to the lungs. Please note that I do not use the term no damage to the lungs because it is highly unlikely that we manage to do invasive mechanical ventilation without causing some trauma to the lung. But our aim is to do as gentle or as physiological a ventilation as is possible. So, why do we need different settings for different conditions? We need different settings because there are different pathologies, and different pathologies have different needs for ventilation. So, let us first look and see how we would ventilate a child with normal lungs, normal heart, and a normal brain. Classically, a child with, say, maybe muscle pathology like a GBS or an SMA, where your heart and lungs are normal. In such a patient, you can use a pressure control mode or a volume control mode, achieve a tidal volume of 8 to 10 ml per kg, pressure initially somewhere around 10 to 12 centimeters with a peep of 5 centimeters of water, which is what we would call as physiological peep. Your rate would be as close to the physiological rate for age. So that would be 30s in the first few years, say till around 3 years, 20s in the slightly older ones till about 8 to 9 years. And for children older than 10 years, we can have a near about adult rate that is around 10 to 20 per minute. In the normal lung, spontaneous breathing creates a decreasing gradient of transpulmonary pressure from the apex to the lung base. The dependent, less distended alveoli are positioned on a more compliant part of the pressure volume curve. The dependent alveoli collectively account for a greater portion of alveolar ventilation. This is important to understand because the dependent alveoli are commonly involved to a larger extent in many of the pathological conditions which we are going to be dealing with. Physiological shunt basically includes the basic baseline VQ inequality, which basically means that there are some alveoli which are not adequately ventilated but better perfused. So, since the ventilation is not good, the blood goes back unoxygenated, and this, along with the bronchial, pleural, and trabecular veins unoxygenated blood, accounts for your physiological shunt. Physiological shunt is to the tune of about 4% of our blood volume. Case-based ventilation, you have different needs for ventilation in certain respiratory disorders, in cardiac diseases, muscle weakness, and in CNS disorders. So we are addressing some one or two case-based studies from the respiratory system. So case one, ARDS. So the first thing you need to understand about ARDS is it is a less compliant or what we call as a stiff lung. To put it in very simple language, the normal lung is like a balloon, fairly simple to inflate, whereas the ARDS lung is like a football bladder. It takes a lot of pressure to inflate that lung. The other important thing is that ARDS is a heterogeneous disease. The involvement is patchy. All parts of the lung are not equally involved, and this is one of the reasons that ventilation in ARDS is tricky or it can be very damaging to the lung. The term baby lungs came about when CT scans were done, and we realized that actually we don't have the whole lung for ventilation. There's only a small portion of the lung available for ventilation, which gave the terminology of baby lungs. And often the dependent areas are far more involved than the less dependent areas. We have a 7-year female child with fever, cough, and breathing difficulty, poor appetite, and no other significant history. The child is restless, intermittently cyanosed, dusky, weighing 20 kg, having a height of 118 centimeters, febrile, with subcostal and intercostal recession. She is borderline hypotensive. Saturations are 72% in room air. Child is tachycardic, and in the chest, clinically, there is a decreased air entry on the right side. The child is irritable, conscious, moving all four limbs. She is given oxygen full flow, 15 liters per minute by a non-rebreathing mask. The saturations now intermittently pick up to 89% and then drop down to 82% again. One bolus is given, samples are taken. Child is still tachycardic, still tachypneic, very restless, has severe respiratory distress, and without too many preliminary investigation, the child was intubated in casualty. After intubation, a central line was put and an X-ray was taken. This is what the X-ray looks like. I'm not going to go into the definitions of ARDS, but this X-ray is showing you a lung which is hazy. So we have a child with a short history, no pre-existing illness. That child is hypoxemic even in full flow oxygen by face mask, tending to drop saturations, has an X-ray chest, which shows you bilateral opacities, more maybe on the right side, and no other condition which can account for this hypoxemia. What ventilator settings will you put for this child? So let me start by saying that if anyone is comfortable with a particular mode of ventilation or a particular ventilator, then they should use that mode. There is no gold standard correct mode of ventilation or ventilator which is correct for any particular disease. So the mode can be what the doctor is comfortable with, can be pressure control or volume control. We prefer pressure control. We have classically been taught that pressure control mode has got a decelerating flow and a square waveform. So today's ventilators, you could use either a PC or a VC. You aim to start your ventilation with a tidal volume of around 5 to 6 ml per kg, and then you can titrate to the blood gases. Ventilation is always started with an FiO2 of 1, and in a respiratory condition, we would start with a PEEP more than 5. Because in most respiratory conditions, you are intubating your patient either because the patient is desaturating or your patient has got a marked work of breathing. In both cases, a PEEP is going to be beneficial. So the child was put on assist control, actually on an SIMV pressure support pressure control, rate of 25 per minute, PIP 15, pressure support 10, 100% oxygen, PEEP 7, inspiratory time of 0.75, which gives you an IE ratio of something like 1 is to 2.2. A MAP is 15, tidal volume is 86, saturations are 86%. This is what our blood gas looks like. The pH is 7.05 and your PCO2 is 88. Oxygen is, I think, 65 or 66. So what does this blood gas show us? This blood gas is showing us an uncompensated respiratory acidosis. It is showing us actually not a marked hypoxemia, but yes, hypoxemia. What will we do? So your carbon dioxide levels are very high. So the only thing that can bring down your carbon dioxide level is to increase your minute ventilation. And how would you increase your minute ventilation? You can increase the rate. You can increase the PIP, which will basically lead to an increase in the tidal volume. And for the hypoxemia, we will increase the P. So we've increased our rate to 30 per minute, increased our PIP to 18, P increased to 8 and then to 10. EtCO2 has been connected. It was first 87 and then it decreased to 76. Saturations are maintained up to 90% and 94, and oxygen has gradually been reduced to 75%. Your tidal volume is 98 ml. Is this tidal volume acceptable to us? We have said earlier that in a child with normal lung, we can ventilate to a tidal volume of 8 to 10 ml per kg. Our patient is 20 kg. This tidal volume is close to 100 ml and it is 5 ml per kg. So now we come to the point of where we will discuss a few basic guidelines for the ventilation in ARDS. So in ARDS, limit the tidal volumes to 6 ml per kg and the alveolar plateau pressure to 28 centimeters of water. What we are basically saying is to ventilate the lung on a slightly lower volume so as not to cause damage to the lung. PEEP is to be titrated to achieve a saturation of around 88 to even 92% on an FiO2 0.5 or 0.6 or less, and permissive hypercapnia unless contraindicated. So what do we really mean by stuff like this? So PEEP helps because the lung has a tendency to atelectasis and the atelectatic units collapse at the end of each expiration. So at the start of inspiration, these units need to be opened up again. So to open up a unit which is completely collapsed requires higher pressure. So then every breath then goes from a low pressure to a high PIP and causes a lot of shear stress to the lung. If you keep the lung slightly open, meaning you give adequate PEEP, PEEP splints the lung. Splints open the alveoli and stops them from shutting off towards the end of expiration. This is termed as the open lung strategy for ventilation in ARDS, and this avoids huge swings of pressure and causes less damage to the lung. There is a downside to this because it stops collapse. It has the potential to overdistend the lung. And if you overdistend the lung, you reduce the venous return to the right side of the heart, and that can compromise your blood pressure and your cardiac output. So, when we are increasing the peak, which is what we are commonly doing initially when the patient is hypoxemic, you increase the peak from 7 to maybe 8 to 10 to 12. It is quite common for us to go up to a peak of 10 to 12. At that point, you need to consciously be watching your blood pressure and volume load the patient if it is required. So this is a picture I'll come back to again. So the picture in the center gives you what is termed as an optimal inflation of the alveoli, which is something which we can very rarely achieve. And the picture on the left side is showing you alveoli which are tending to collapse, which is a de-recruitment in the lung. And on the other side, you have alveoli which are ballooning and they are somewhat over-distended. So this concept of optimal PEEP or getting your PEEP absolutely right is actually a very difficult thing to achieve. So we'll come back to that. But right now, with no change in ventilator settings, our saturation has started to drop and the FiO2, which had been reduced to 75%, has been brought back to 100%. EtCO2 has risen is 86, saturations are again drifting downwards. Child is tachycardic and an ABG was done. Before I go to the ABG, I want to emphasize one point. At any point in time, when a ventilated patient starts to deteriorate by way of oxygenation or a rise in carbon dioxide, somewhere at the back of your mind, there should be a dope which is to be ruled out. So tube in place, tube not obstructed, your no pneumothorax, and your vent and tubings functioning perfectly all right, meaning to say that your tubings don't have too much water, there's no disconnect somewhere, there's no alarm ringing somewhere. All those things have to be sorted out first. I'm not going to go through a pneumothorax and put an ICD because that is not a part of this basic pathology. In any disease, when we are ventilating, it is common that the disease is not static. So your patient can be improving or your disease process could be worsening. And in an ARDS, which we have just ventilated about 3 or 4 hours down the line, we definitely expect that chances are that the lung is actually worsening at this point in time. So this is what the ABG looks like. The pH is 7.18, PO2 40, PCO2 85, and the other parameters appear to be normal. So what are you going to do? Your oxygen is low, so we increase the PEEP from 10 to 12, and then to 14. What about the carbon dioxide? Is this carbon dioxide acceptable to us? So permissive hypercapnia is a concept in which we tolerate higher carbon dioxides so that we don't have to increase the pressures to wash out this carbon dioxide. So permissive hypercapnia can only be allowed to happen if your pH allows you to do so. So if your pH is more than 7.20, you can tolerate a carbon dioxide on the higher side. That said, there is no clear-cut number of what cutoff of hypercapnia we are willing to accept. Now, this carbon dioxide is 85. If we are willing to accept this, are we willing to accept 90, 100? So what it basically boils down to is you will tolerate a higher carbon dioxide if your patient is not on any inotrope support, doesn't have a cardiovascular compromise, and you are quite sure that there is no CNS involvement. Because any kind of CNS involvement means that a rise in carbon dioxide is going to lead to a rise in intracranial pressure. It also must be kept in mind that though we tolerate carbon dioxide levels of 80 to 90, very high carbon dioxide levels must still be viewed with suspicion and every attempt made to kind of bring them down. So, but as of now, 85 we are going to tolerate. So we are on a PEEP of 14, a rate of 30, a PIP of 18, oxygen is 100%. So that's a lot of oxygen, and oxygen we know is toxic for the lung. The plateau pressure is 28 millimeters of mercury. We have two questions here. How much PEEP and what is the significance of this plateau pressure? So optimal PEEP is when oxygenation is maximized. There's minimal end expiratory atelectasis and minimal end inspiratory overdistension. So we are really actually asking for utopia. I mean, your alveoli should not collapse. They should not overdistend. There should be a perfect inflation of the alveoli. That rarely happens. But technically, if we set the PEEP slightly above the lowest inflection point, is when we get an optimal PEEP. So let me try and explain this concept to you. This is a PV loop, or what we call as a pressure volume loop. So you have your pressure on the x-axis and your volume on the y-axis. If you look at this, see from 0 to 10, your pressure has increased without any significant rise in your volume. Means this is kind of largely sitting atelectatic lung. Over here, your lung has started inflating. So this is what we term as the lower inflection point. And at 2 centimeters above this is your optimal PEEP. When we look at this part of the lung, this curve, this is the area where you have atelectasis. When you look at this part of the curve, then you know that in this area you are likely to get a overdistension. So look at it like this. So this de-recruitment is in this area. This overdistension is in this area, which is tending to peak. And this optimal PEEP or optimally open lung is this. This is the area in which we are aiming to ventilate. So how do we get to optimal PEEP? To get to optimal PEEP, we have certain maneuvers. They're very complicated and it would take a whole lecture to come to that in itself. So right now we are going to take it as we'll increase the PEEP up to the point where increasing the PEEP is improving our oxygenation. And once it is no longer improving our oxygenation, we will not increase it any further. So rate of 30, oxygen is 100%. So there isn't much scope here to increase the oxygenation. The plateau pressure is 28 millimeters of mercury. So there isn't much scope here to increase the pressure either. What exactly is P-plat? So P-plat is what we term as the pressure which is in the alveoli at the end of inspiration. And this is the point at which there is no flow of air in the lung. Classically, plateau pressure is measured in an inspiratory pause in volume controlled ventilation when your patient is muscle relaxed. Does that mean that we can't calculate a plateau pressure in pressure controlled ventilation? No, that's not true. You can get the plateau pressure and pressure controlled ventilation too now, as you can see in this particular graph. So basically, what we are saying is that the guidelines for ventilation or the PALIC guidelines advise that the plateau pressure not exceed 28 millimeters of mercury. So what we are saying is the plateau pressure is 28, your PEEP is 14, and your FiO2 is 100%. So there isn't a great deal that you can do right now to improve your ventilation by just playing around with the knobs on the ventilator. So what can we actually do right now to increase the oxygen saturation of our patient? So we have 2 or 3 options, and the common options are recruitment maneuvers, proning, and inverse ratio ventilation. Recruitment maneuvers are maneuvers in which you increase the pressure, the PEEP actually, to a very high number for a short period of time with the aim of opening up alveoli or recruiting alveoli, and then you reduce the pressure, hoping that some of those alveoli at least will stay patent. This is not without its own set of risks. Number one, increasing the PEEP to a very high number compromises venous return. Number two, you're dealing with a very stiff, non-compliant lung, and you increase your risk of a pneumothorax. So recruitment maneuvers are something that only skilled people should do and only in a very guarded fashion. The other thing that you can do to improve a refractory hypoxemia is to prone your patient. And the third thing is inverse ratio ventilation. So since I'm going to be talking about proning a little more, I'll touch upon inverse ratio ventilation right now. As the term states, inverse ratio ventilation is a situation where you change the ratio of ventilation from short inspiration and long expiration to a long inspiration and a short or an equal expiration. So our normal IE ratio in ventilation is 1:2 or 1:3 even, with a short inspiration and a long expiration. So when you prolong the inspiration, give a longer time to the lung to oxygenate. But you can only prolong the inspiration if your carbon dioxide gives you the liberty to do so. If your carbon dioxide is high, then shortening the expiratory time is going to lead to a compromise in your carbon dioxide levels. So inverse ratio ventilation is not something we do very common. Proning, however, is our first resort when our patient starts to get hypoxemia. So under normal circumstances in ARDS, in the supine position, the dorsal or the dependent regions of the lung are more susceptible to de-recruitment, basically because the dorsal part of the lung is subjected to the pressure exerted by the heart, the pressure by the lung mass itself. The fluid tends to go into the dependent parts and there is accumulation of fluid in that space. And in the supine position, since the diaphragm comes up higher, the pressure is exerted by the abdominal contents also. And because the lung compliance is lower in the dependent region, so you have a great deal of dependent part of the lung being compromised. So when you look at ARDS, you're going to see in the supine position that the dependent part of the lung is almost all atelectatic. Then you have the part which is absolutely anterior, which is either normally inflated or tending to overinflate. And then you have the middle portion, which is possibly the part of the lung which you can actually recruit or open up. So now in this picture, you see in the supine position, these are the dependent areas of the lung, which are compressed by the heart, they are compressed by the lung itself, and they are atelectatic. And in the same patient, when you turn this patient prone, this part of the lung, the dependent part is the larger part of the lung, it has started to open up. So prone position definitely results in more even alveolar ventilation. It results in reduced compression of the lungs by the heart and the lung. It decreased lung compliance in non-dependent region, less pressure from the abdominal contents. It facilitates the drainage of secretions, and therefore VQ matching improves. So we proned our patient. So this is an X-ray in the prone position. As you can see, the line is, looking a bit peculiar. And this is the blood gas once the patient has been prone. pH is 7.17, PCO2 is 81, oxygen is 50. We are tolerating slightly lower oxygen saturation in this. So in addition to permissive hypercapnia, we are also allowing for a permissive hypoxemia, but not really hypoxemic, because as you can see in this, your pulse ox saturation is 89%. What you need to understand about the ventilation of ARDS is there's just very rarely hypoxemia that kills the patient. Obviously, if you have an oxygen saturation to the tune of 60%, it may kill your patient. But by and large, the saturations that we see in the 80s, high 80s, even in the low 80s are unlikely to kill the patient. The carbon dioxide too is unlikely to kill the patient. It is our aggressive ventilation that has chances of causing ventilator associated lung injury, which over a period of time causes a lot of systemic inflammatory response, leads to the release of endotoxin, free oxygen radicals, and those over a period of time are almost as likely as the disease to cause some kind of long-term damage and even death. So child improved with prone ventilation. So the aim is for early proning. So you should not delay proning. If your patient is not improving when you are ventilating in the supine position, the patient should be prone. Early proning, prolonged proning. So many people advocate a proning for 3 to 4 hours with then supine position for 1 hour, then prone for 4 hours, but that is practically impossible to do. So proning should be done for about 16 to 18 hours a day. and it should be done for as long as needed. That is, till your ventilation improves. And we ideally say till your PaO to FiO2 ratio comes to something like 150 and your PEEP is less than 10, oxygen is less than 60%, then back to conventional ventilation when the patient is improving. Often proning is done for 6 to 7 days and even for much longer. Proning is one thing which is shown to known to show a mortality benefit in ARDS. So, what other options are there to improve oxygenation and ventilation if conventional ventilation fails? So, there are some more complicated modes of ventilation also, like APRV and bilevel ventilation. There are some other modalities like inhaled nitric oxide, surfactant, but none of these have been known to show a mortality benefit. Some of them do show a benefit in oxygenation, like nitric oxide, but they don't show any mortality benefit. In practical situations, they are rather difficult to do if you are not familiar with them. If you do not get an improvement in ARDS with your conventional ventilation, then your options are HFOV and ECMO. Is there any role for steroids in early ARDS? The controversy of steroids in ARDS never really seems to end. But for all practical purposes, apart from COVID, there is no indication for steroids in early ARDS. There is also no recommendation for ancillary treatment like helium oxygen mixture, prostaglandins, plasminogen activators, fibrinolytics, ipratropium, nebulization, N-acetylcysteine, antioxidants. None of these things are going to help in ARDS. ARDS is a self-limiting disease. Finally, it does start to improve. Your ventilation is supposed to guide it through. This is day 9 of PICU of our patient. Child was extubated and put on BiPAP. Our second case is bronchiolitis. 4-month male child, born preterm, 32 weeks, 1.8 kg. Stay of 10 days in neonatal ICU for hyaline membrane disease, given surfactant, not ventilated. Now, cough 5 days, low-grade fever, and increasing respiratory distress. In casualty, 4.8 kg baby, saturation 92% in oxygen by face mask, heart rate 186, respiratory rate 82, significant tachypnea, significant distress, peripheries cold, baby restless, and as is the norm these days, we put this child on a humidified high flow nasal cannula. So let me start by saying that even though I am presenting this as a ventilation of bronchiolitis, the rule of the book now is that by and large you should be able to manage a bronchiolitis with HFNC. Ever since we started using HFNC, we have rarely ventilated a bronchiolitis. Bronchiolitis is actually very difficult to ventilate. So child was given an oxygen 40% flow of 10 liters, nebulized with normal saline, given some mild sedation, still very restless. Saturations are dripping intermittently. Oxygen increased 50, 60, 70%. Saturations are still not really very satisfactory. And finally, because the child is so restless and desaturating, the child was intubated. So what are the indications for mechanical ventilation in babies with bronchiolitis? So apnea or recurrent episodes of apnea, a decreased level of consciousness or marked irritability. You use a lower threshold in a high risk group like premature babies, pre-existing respiratory conditions like BPD, or children with congenital heart disease or neuromuscular conditions who may not even show you significant signs of distress. Once you've put the patient on HFNC, the child does not improve or actively deteriorates, or you have a very high oxygen requirement to maintain a saturation of 90%. So after ventilation, this is your blood gas. Respiratory acidosis. This is actually a venous blood gas because most of the times in bronchiolitis, we don't often put arterial lines immediately. This is a venous blood gas, but this is also showing you a very high carbon dioxide. So bronchiolitis often have a significant ventilatory drive with forced expiration. There's a lot of sympathetic overdrive. So it can be hard to match this with positive pressure ventilation. And you should expect that these babies will decompensate during intubation because of the loss of the sympathetic drive. So be prepared with the fluid bolus, inotropic support, and check your intubation checklist. So this child was put on pressure control, pressure support rate 36. This may be one of the reasons why your PCO2 is so high, because this child was breathing to almost 90 and you have put him on a rate of 36, so your carbon dioxide has risen. I time of 0.7, peak of 6. And basically, in bronchiolitis, do you need to nebulize on the ventilator? So this is a bit of a tricky question. So here I'm just showing you that this is the nebulizer chamber and this is the T piece or T connector, which is the connector which you need to nebulize on a ventilator. This is attached into the inspiratory limb. But in bronchiolitis itself, there is no role for nebulized therapies. No salbutamol or nebulized hypertonic saline or adrenaline or any of those. There is really no recommendation for any of all this. It does not change the severity, length of stay, or length of illness, and it can actually delay escalation to critical care when you are using nebulizers in the child who's being given oxygen by face mask or HFNC, and you're nebulizing them in the hope that they are going to improve. The pathology in bronchiolitis is a little more tricky. There's a lot of mucus plugging and edema. There's a tendency for the airways to collapse. So they need CPAP more than any other very high pressures they don't need, but they need PEEPs or they need CPAP and antibiotics if there's fever or pertussis, and gradual reduction of pressure as the patient improves, and they're often extubate to nasopharyngeal CPAP. So this child the problems with bronchiolitis are basically in keeping them sedated when they're ventilated, and very often avoidance of neuromuscular blockage should be the rule for them. So single lung ventilation is something we've put in this, but truly speaking, this is not the domain of either the pediatrician or the intensivist. But a little bit of information about this. Single lung ventilation involves ventilating one lung and letting the other lung collapse for providing surgical exposure in the thoracic cavity or isolating ventilation to a single lung. You can sometimes do one lung ventilation to give protective role of ventilation to protect one lung from the ill effects of fluid from the other lung, and that fluid can be blood, pus, malignant secretions, or lavage fluid. So because you want a single lung ventilation, it is mandatory that the tube placement be perfect, as a misplaced tube defeats the goal, or you lose the purpose of the whole thing completely. So you need bronchoscopy for adequate placement, and the right person to do this is the anesthetist. You need single lung ventilation for video assisted thoracoscopic surgeries, pulmonary dissections, esophageal surgeries, spine surgeries, not our domain. Massive pulmonary hemorrhage for control of ventilation in tracheobronchial fistulas and bronchocutaneous fistulas. You get what are termed as DLTs, that is double lumen tubes, and with that, lung ventilation is done. So technically speaking, you could kind of intubate the right main bronchus if you wanted to ventilate just the right lung, but that is not the way it is done. And you do a double lumen tube and put a bronchial blocker into the other side, which you do not want ventilated. As I said, this is not truly our domain. I have just mentioned it here to complete this presentation. So I hope this presentation is easy for you to understand, and thank you for a patient hearing.